Well, it's a pleasure to be with you this afternoon and to represent Organized Dentistry on the coalition panel for Medicare dental benefits. And I've had a few people come up to me and say, so what are you going to talk about? And I'm here to tell you that it is not necessarily an oxymoron. So it's a pleasure for me to be here. This is my PowerPoint, and I chose that slide on the far left to represent the cohort of boomers. And they've been described moving through their lives as the pig and the python, or now they're the silver tsunami. But I think it's important to realize that the millennial cohort is about 20% larger than the boomers. So think about a distant relative of the pig, the rhinoceros going through the python. It'll make the silver tsunami look like a ripple in a pond. So I think we need to think about that as more and more Americans age into Medicare and what that's going to mean for this country. And Organized Dentistry, I think, understands that. And I'm here to tell you they will. So my disclaimer. I am currently not a fiduciary of any organization, and this presentation represents my thoughts on the subject only. So I have spent most of my professional life in organized dentistry leadership. I was on the executive committee of the California Dental Association. I was the president of CDA in 2013. After that, I moved on to the ADA Board of Trustees, and I'm an immediate past member of the ADA Board of Trustees. So basically, I'm a has-been from two major two organizations in organized dentistry, and I have the pins on my lapel to prove that. So I thought it was important to share the ADA mission statement, the new one, which was just approved by the ADA board in February. The previous mission statement, to help all members succeed, obviously describes only, it represents only a focus on membership and members. The new mission of the ADA is to help dentists succeed and support the advancement of the health of the public. So it serves a dual purpose of not only the members, but also the oral health of the public. And the new vision statement, empowering the dental profession to achieve optimal health for all. So key words in here, optimal health, not just oral health, but health. And that to me describes and represents a thinking more broadly in terms of where oral health fits into overall health for all people, not just patients, but everybody. So let's move on to Medicare policies in the ADA. And the history of Medicare policy in the ADA is somewhat schizophrenic, as it has evolved over the years. The earliest policy I know of dates from 1977, which actually supported dental benefits being included in Part B. This was amended in 1986 by deleting the reference to Part B and adding the stipulation that enrollment be voluntary for beneficiaries. And in 1989, this policy was eliminated, rescinded in its entirety. So throughout the 90s, Medicare policy in the ADA was really more about emphasizing the freedom to choose a dental provider, and if Medicare offered dental benefits, that it would be targeted to a population of seniors in long-term care facilities or the homebound. So these next two slides represent the most current policies related to Medicare. This policy, the elimination of disparities in coverage for dental procedures provided under Medicare, dates from 1993, and it attempted to expand the number of conditions eligible for medically necessary dental services provided under Medicare. So I've highlighted the key words and phrases, and you'll notice actually it uses an action statement to seek legislation. And emphasizes under Part B of Medicare, and this is current policy. And then this policy, medically necessary care, dates from 1990. This policy was actually offered by the ADA for use in defining the dental benefit in federal statute for the Children's Health Insurance Program Reauthorization Act of 2009, another example of coalition work that the ADA has done in the past. And these policies have allowed the ADA to sign on in support of this consensus statement that Eric had everybody take advantage of. So this was all here before you, and you'll notice that the American Dental Association is a signatory to this statement, as well as California Dental Association and some other prominent organizations that represent dental providers. So I think it's important to realize that these groups obviously don't always agree with each other, but in this case they do, and the policy statement allowed the ADA to sign on to this. So I think we all recognize the importance of coalition building and being a part of coalitions, and the ADA does certainly do that, because as a dentist, you can't just be an island. You can't just say, okay, you do this, and expect everybody to go along with it. So this actually it's kind of interesting. This is not a current, good, modern example of a dentist in the U.S., an older Caucasian male, when the reality is the demographics are shifting so much. I found this interesting. This picture is actually an advertisement for a mouthwash, Levoris chemical company, Levoris mouthwash. Some of you may remember that. This is from the 30s, and it was in the Saturday Evening Post. But when you look at the small print in there, I thought it was extraordinarily futuristic. It says, "Know your dentist, and so know more about yourself. For your dentist is more than a repairman. He is a staunch ally of nature and medicine in the crusade against disease and pain. When your dentist suggests that you consult a physician, do it. He wants to safeguard you from needless suffering, protect you from troublesome systemic disorders like rheumatism, arthritis, heart and kidney afflictions that can arise from oral defects." I thought that was really interesting. It's somewhat paternalistic in the way it's framed, but I thought that was pretty cool. So what do we know about the rank and file dentist? What do they think about adding a Medicare dental benefit? And so what we know is this, and this is from Marco's shop. HPI conducted a survey of a random sample of U.S. dentists in January of 2018. And this actually, some of you may remember that this was published in the Families USA white paper last July. Half the dentists surveyed agreed with the statement that a comprehensive dental benefit should be included in Medicare. And on the flip side of that, only 21% disagreed. They also found a strong support among dentists for a comprehensive benefit regardless of age, gender, or ADA membership. Most dentists were more likely to participate if the ADA helped design the benefit, and that if it paid 80% of average commercial insurance rates. So I think, and Marco alluded to this the other day in his presentation, that the microeconomics of a small private practice, it has to work in order for a dentist to take any kind of coverage. I don't care if it's Medicare, Medicaid, it's got to at least work within the payer mix of the individual practices. We also know from HPI that practice patterns are changing, and there are a lot of reasons for this. The demographics are changing with more women, ethnically diverse, and millennials graduating from dental school. And they graduate with a significant amount of student loan debt, and they need to get a job right away. So 6 months grace period, and then student loans start. We also know work-life balance is important to them, and they are used to working in collaborative groups. Millennials like working collaboratively and in groups. From 1999 to 2017, there was an overall decline in solo practice. So as of 2017, only half of dentists are in solo practice. Only 1 in 5 dentists under 35 are in solo practice. This is partially due to an increasing number of women in the workforce, and women are less likely to be in solo practice and owners. This trend will increase as more schools tip the scales of enrollment towards more than 50% female. And we're all aware of how professional education has changed following changes in accreditation standards and a focus on whole person collaborative team-based care. All dental schools now are required to provide an exposure to this delivery model. And some schools provide place a greater emphasis on it, and they also have the ability to co-locate professional students under one roof. I love this example here. I love the alliteration. Interprofessional education, fluoride and a physical, patients see docs at the dentist. And Harvard does a great job. NYU was a pioneer. You took a lot of slings and arrows to get that done, and thank goodness for that you talked about perseverance. I think that perseverance runs, that's a theme that runs across this entire meeting. With our new dentists graduating with this experience under their belt, I believe there would be a greater interest in practicing this way as being part of a primary care team. But there are very few places for new grads to practice in this way. And I hear that all the time when I talk to ASDA members and new dentists who have been in leadership, and now they move out. They've been very involved with this interprofessional educational experience, case management across disciplines. It's so exciting. But then they get out. They have 6 months grace period. They have to find a place to work to pay off their student loans. There's no place to go. A lot of them more and more are going into corporate practice, which provides a very good opportunity for new grads. But there really are very, very few opportunities to allow them to practice in this way. Here are a few here. Care More Health is starting the interprofessional, the medical dental integration. They're also going to be collecting data in terms of the impact on overall health. Kaiser Permanente, Beaverton, Oregon is an incubator for medical dental integration. And then finally, Pacific Dental Services has an office, I think that's in Arizona, and they're testing the branding of, I don't know how much they're actually, I'd like to know more about kind of the integration, what they're doing in the office, but they're testing the brand to see if consumers, how consumers will feel about that and see if it's something that will work. So I need to talk a couple minutes about the perspective of our dental professionals, and Marco alluded to a few of these earlier. Experience with government programs has been mostly negative, and that's Medicaid programs. And that's, unfortunately, there are 51 plus Puerto Rico examples of Medicaid, and they vary across states. And so many states underfund their Medicaid programs. Some states will have eliminated adult benefits, and as a provider with a payer mix that includes Medicaid, adult Medicaid, and they just pull the rug out from under people, clinicians, what do? You're stuck. And so when adult benefits are reinstituted in states, it's really hard to find providers who want to sign up again. So and there's a bit of conflation with Medicaid and Medicare. I think there's just an overall lack of understanding about how Medicare is financed. It's at the federal level, it's administered at the federal level, it's a very different program, and there's conflation there in the minds of clinicians. The administrative and regulatory burden is unknown. We have no idea what impact it will have on individual practices, and that's the lack of knowledge and the unknown is very scary to clinicians. Most are in private practice and small business owners. They have a high overhead with laboratory costs, especially for for adults, adult dental services, and there would be no ability to get a facility fee to offset that part of the overhead. Reimbursement from commercial insurance products is declining. PPOs on the commercial side are paying less. So the overall payer mix is going to be more important. And a lot, Marco said that the driver in a lot of practices is cash paying seniors. And if they have a Medicare benefit, how is that going to impact the individual practice? That's a big concern. The Medicare program is not truly means tested. Not everyone needs it, so why not prioritize those who most need it with limited resources? And this is the mind of clinicians who are thinking about that and making decisions from their own personal experience. Many of these are in organized dentistry leadership. Why not prioritize for those seniors who truly need it, the ones who should have had a Medicaid adult benefit, who don't have the ability to gain that, and they get to age 65 and there's all this pent-up demand for services that will never be, you can't never get over. The fire will always be fueled unless you offer Medicaid. You've got these people who are just in a really bad way by the time they achieve Medicare eligibility age. Older adults who really need the care may still have difficulty accessing it, even with a dental benefit. And as a pediatric dentist, I've find that with my Medicaid population. There are so many kids who just can't, for whatever reason, can't get into the office. And I really appreciated what Meg Booth was saying about the importance of going out to the community where these people are. We need to think outside the four walls of a dental office. So most dentists are conservative and believe in a private sector solution versus expansion of an entitlement program. I've heard that across the ADA membership, the vast majority are conservative. Dentists tend to be conservative. They're small business owners. They think in that way. And most of them really think the private sector is a better way to go in terms of expansion of a large entitlement program. So before I conclude, I just wanted to mention this, the National Academy of Medicine Dental Collaborative, which is under the umbrella of the National Academy of Medicine Health Literacy Roundtable. I've had the privilege to be a member of that roundtable for 5 years. And we have the ability to start a dental, or it's actually, we actually are now called the Oral Health Collaborative. The Oral Health Collaborative a few years ago, which we chose to focus on the goal of catalyzing action in the use of health literacy practices to promote integrated, coordinated, and patient-centered care. And there were a few of us on the roundtable who got together around this topic, and we reached out to two outside folks from the roundtable, David Gesko and Alice Horowitz, to help us in that work. And the first thing we did, the first action we took was to commission a paper. And that paper was authored by Catherine Atchison, Gary Rozier, and Jane Weintraub. And if you haven't read that paper, please go to the website. I'm sure pretty much everybody, all the Santa Fe group folks have, because Catherine has been a scholar here and researcher. It is a phenomenal paper. Our roundtable believes it's one of the best commission papers we've ever received, and it's well worth the read. It's a large paper. They did just the most remarkable job in looking at the literature and pulling out all the important information, looking for case studies around the country. It really provides a framing for doing research and how you think about interprofessional collaboration, multidisciplinary care for the future. So we convened a workshop in December, and we introduced the paper, and the proceedings of that workshop will be published very soon. Several people in the room here were speakers for that workshop. It was a fantastic experience, and the roundtable really appreciates everything that we've done in terms of the Oral Health Collaborative. I think we've opened their eyes to, in terms of what dentistry and oral health can bring to the table. So it was really a wonderful experience. So in conclusion, coalitions amplify the voice of oral health to policymakers and regulators. That's very clear. We've heard so many examples today of that. Collaborative practice model is taught in dental school and fits the millennial team orientation. Increasingly, more new dentists will seek opportunities to practice in collaborative groups. Just build it and they will come. Research supports the existence of a sufficient provider network. Marco showed that. ADA leadership needs to provide direction on how to implement their own policy. And if I were still on the board, I would encourage my fellow board members to recognize that the policy exists, to at least sign on for medically necessary care and support that more actively. Strengthen the evidence base by conducting prospective studies on the relationship between chronic disease management and dental care. That's ongoing. There's especially on the commercial side or in health systems that will be happening with CareMore, and Kaiser also has the incubator up in Oregon. And finally, dentistry can and is poised to become an integral component of primary care through improved health outcomes, reduced cost, and better patient-provider satisfaction, which is the quadruple aim. I think dentistry, the dental provider community can do a lot in terms of easing the burden of primary care on the healthcare side. There's so much bi-directional work we can do together. We just need to figure out the logistics of how to make that happen. And with that, thank you very much. This is a picture of my favorite Medicare beneficiary, my father, retired dentist, Richard Robinson, my sister and myself. We're all oral health folks. My sister's a hygienist in California, and my father absolutely loves his Medicare benefits at the age of 82. Thank you very much.